Thanks for joining our Precision Medication Center of Colorado short patient scenario regarding multiple tools we use to perform a comprehensive medication review after a fall for a patient referred to us. Falls are serious events that are multifactorial, and sadly about 95% of hip fractures happen due to some form of a fall. Medications can cause falls and are what is known as a modifiable risk factor. These need to be evaluated ideally before, but certainly after, a fall. A reported fall often necessitates what's called a comprehensive medication review, and with a board-certified geriatric pharmacist, we at Precision Medication Center of Colorado are trained to look for any new medications or any dose increases, in particular in certain classes of medications, such as antihypertensives, benzodiazepines, tricyclic antidepressants, antipsychotics, opioids, diuretics, and more. What is looked for is called a FRID, which stands for Fall Risk Increasing Drugs, and calculating DBI, which is the Drug Burden Index, a method for measuring the total exposure to anticholinergic and sedative drugs. Generally, recommendations center around decreasing polypharmacy, safe deprescribing, and dose reduction via gradual discontinuation. We have various tools in our pharmacist toolbox to help patients like this patient case right here. This is an 81-year-old female in an assisted living facility with 4 falls in the past 6 months. Her last fall was severe enough that it required an emergency room visit with multiple interventions. Her daughter contacted us and requested a comprehensive medication review. She has a past medical history significant for GERD, overactive bladder, insomnia, and neuropathic pain, for which she takes 4 medications. While it looks simple, these 4 medications all have an impact on the drug burden index, especially oxybutynin, diphenhydramine, and amitriptyline. Our first recommendation here was to stop and deprescribe the diphenhydramine and use an alternative medication for insomnia. This medication is associated with a very high anticholinergic burden, which can be associated with what we call prescribing cascades. The high anticholinergic burden of this medication can cause side effects such as overactive bladder, for which oxybutynin would then be used. Once we successfully stop the diphenhydramine, we can then reassess to see if the patient truly needs oxybutynin. If it is still needed, we recommend the immediate release over the extended release, as extended release can accumulate due to longer half-life in our elderly patients. Ppi dose reduction was also suggested. If it's possible, we request that the medication be used on demand or as needed, as PPIs are associated with an increased risk of fracture and multiple other side effects. So we are always looking for opportunities to deprescribe or at least reduce the dose of PPIs in our elderly patients. Amitriptyline is one medication we would have liked to see discontinued as well. We could recommend that the patient get a pharmacogenomic analysis done to have guided therapy towards a better neuropathic pain management recommended. However, if a PGX is not done or is not warranted, then other medications could be suggested here for amitriptyline, as amitriptyline is associated with a high risk of anticholinergic burden and is not the best choice for someone with a history of falls. We hope this patient case was useful to you. At Precision Medication Center of Colorado, we value our collaboration with providers and their referral. If interested, please feel free to view our other patient scenarios. Thank you.